Good evening, everyone. Thank you for attending Red Nose's Research and Education series. My name is Craig Pennell. I'm the Professor of Maternal Fetal Medicine from John Hunter Hospital and the University of Newcastle, and I have the privilege of being the chair of Red Nose's National Scientific and Advisory Group. Tonight we have three excellent presentations and a discussion with a family who've been involved with perinatal loss. The topic for tonight is best practice care after stillbirth and neonatal death. I'd like to begin by acknowledging country. Red Nose acknowledges the traditional custodians of the land in which our families, volunteers, staff, board and committee members work, live and visit. We pay our respects to elders of past nations from past and present, recognising their continuing connection to land, waters and the community. Red Nose respects the knowledge and expertise of Aboriginal and Torres Strait Islander people with their strong culture and traditions, whose hands have touched many babies birthed and children reared on the land. And together we acknowledge their experience of loss in many forms. Tonight we have three speakers. The first speaker is Professor Adrienne Gordon. She's a senior staff specialist at Royal Prince Alfred Hospital as a neonatologist for the Centre for Newborn Care and clinical professor in the discipline of obstetrics, gynecology and neonatology at the University of Sydney. She's trained in paediatrics prior to specialising in neonatal and perinatal medicine and is passionate about the public health impact of a healthy start to life and preventing adverse pregnancy outcomes, especially stillbirth. She's the chief investigator of the NHMRC Stillbirth Centre for Research Excellence, a board member of the International Stillbirth Alliance, president-elect for the Perinatal Society of Australia and New Zealand, co-chair of the Perinatal Society of Australia and New Zealand Impact Network, and she has many other amazing and important clinical roles. She has strong links with the national parent-led organisations, including Stillbirth and the preterm birth advocacy groups, and is the deputy chair of the Red Nose National Scientific Advisory Group. Professor Gordon co-leads the Novel Interventions program of the Stillbirth CRE and leads the MRFF-funded pre-babe trial, which aims to improve pregnancy and newborn outcomes for women with overweight and obesity. She founded the award-winning Sydney Local Health District ISAIL service, which is the Integrated Support Service After Infant Loss. She's a key member of the Safer Baby Bundle initiative, which aims to reduce late pregnancy stillbirth in Australia by 20%. Adrienne chairs the Perinatal Mortality Review Committee for New South Wales Clinical Excellence Commission, and she's the immediate past national coordinator of the Improve program. Our second speaker tonight is Associate Professor Fran Boyle. She's a health services researcher at the University of Queensland's Institute for Social Science Research and co-lead of the Care After Stillbirth program at the Centre for Research Excellence in Stillbirth and a member of Red Nose's National Scientific Advisory Group. Fran has a background in psychology and public health and is engaged in health service research and evaluation in a range of hospital and community settings. She's strongly committed to ensuring that care is informed by the latest best practice evidence. Fran's work is also driven by the firm belief that consumer perspectives and understanding of people's lived experience of health and their healthcare systems are essential in developing responsive and effective policy and practice. Fran is passionate about improving perinatal bereavement care and ensuring that all parents receive the best possible care when a baby dies. She's been closely involved in the development of the clinical practice guideline, including the 2024 edition of the Care Around Stillbirth and Neonatal Death Clinical Practice Guideline, and led the development of a parent version of this guideline called Guiding Conversations. Like many who are drawn to research and practice in this area, Fran's involvement began with her own lived experience of loss of a baby shortly after birth. Her PhD looked at the psychosocial consequences of stillbirth, neonatal death, and SIDS on families over time, and she has since published numerous articles on this topic and that of perinatal bereavement care. Fran has a deep understanding of the widely varying needs of parents following pregnancy loss and the essential role of parent-focused organisations such as Red Nose in helping those in need. Our third speaker is Skye Stewart. Skye is a Wamba Wamba. Skye is a Wergaia and Wamba Wamba midwife researcher and creator of the nation's first bereavement support guide for First Nations families. In 2024, she was awarded the prestigious HESTA Australian Midwife of the Year Award for her tireless and innovative work for First Nations families. Currently, Skye is working at Red Nose, and Skye continues to work in the prevention and bereavement space of stillbirth, SIDS, and SUDI for Aboriginal families. Her cultural role is to do what she can to make sure that Aboriginal families and their babies stay safe, alive, well, and together. Family stories are an important part of the history of Red Nose. At all board and staff meetings, a family impact story is shared to highlight the important work that Red Nose carries out in the community, so we never forget the families that we care for, and we're reminded that they are not statistics. Tonight we'll begin with a story from Mark about baby Elizabeth Fiona's story. I'll hand over to you, Mark, now.
Thanks for some time to talk through this. So one, we have four kids, and Elizabeth, and all of our kids were through IVF. So we spent many years being told my sound is not great. Change it.
Maybe if you turn your screen off, Mark.
Is that better?
Yes.
Perfect. So our family story, we have four wonderful kids, as well as Elizabeth. All our kids were conceived through IVF, so a lot of struggle to conceive. So anytime we did, it was like a mini miracle. So when we got to number 4 and we were told we were having twins, it was fantastic. Not a challenge we had planned for, but one we willingly accepted. And when we were told it was a girl and boy, they just added to it. So we're in a position where we couldn't believe our luck. And from my perspective, I knew that had finally wrapped up the conception side of things for us. So we were really looking forward, and obviously starting to plan a life with 5 kids. So fundamental changes around where would everyone live, what kind of car we would need. So we were planning a lot. We were talking to a lot of our friends. Everyone was very excited. It was a few months in that we noticed that Elizabeth and her growth wasn't quite tracking at the same as her brother Banksy. So we were told not to worry about it. These things happened. Growth rates can be different. So we waited and we watched without little concern. As the month went on, it became more and more distinct that the growth was different. We did consistently ask if that was normal, and we were constantly reassured that, look, it's not great, but it's still okay. It wasn't until quite a way in and an appointment I unfortunately didn't attend that Fiona was told that there was something wrong. Elizabeth's growth had basically ceased. And we needed to investigate. What was found was that her umbilical cord had a deficiency, and blood flow was just not keeping up with what was needed for development. So we didn't know what was going to happen, and it was a matter of waiting and seeing how the development went on. We were given a range of potential outcomes from some minor developmental delay to severe to potentially neonatal death. So we didn't really know what was going on, but we knew we were in for a challenge. That really changed my wife's personality, from someone who was just full of life up at the crack of dawn and still going at 11 o'clock. She began to close down, and obviously thought a lot of what she had done to cause the issue. As things proceeded, the news didn't get any better, and it became pretty clear that Elizabeth was probably not going to make it all the way through. So our concern actually then turned to Banksy and what needed to happen. Again, many late night conversations around termination of Elizabeth and the practicalities of what that would mean for Banksy. We were told about the complications of going to full term if Elizabeth did pass away, and what that could mean, and the health risks for Banksy and potentially losing both. So we were given a number of scenarios. None of them really had an option that we wanted to take on. So it was, as I said before, a matter of just waiting, see how things progressed. Fiona was put on bed rest, so spent all her days in the bedroom. Meanwhile, I was still working a full-time job. We had 3 kids that were still at school. It was also the onset of COVID, so there were challenges around just what was happening external to our family. But we also noticed at that time that as we started to discuss what was going on with our close friends, people started to drop away as well. Only a few friends remained connected and wanting to listen. My wife, being a journalist at the time, was more than happy to put things on social media. So everyone knew, but we made a decision as a family to kind of bunker down, close off social media, and just try and do what we could to kind of secure our family unit as things went on. As a bloke who couldn't solve the situation, couldn't really change any of the outcomes, I turned to the only thing I knew at the time, which was, well, I'm going to build something. So I spent any spare time I had out the backyard building a yoga studio in the hope that at the end of this, Fiona will have a place to go and get away from life and focus on herself. It was quite interesting after the fact, with a discussion with a psychologist, that I had shown basically a very common quintessential bloke's reaction to any challenge. If I can't fix it, well, I'll go and build something. So as things went on, it was actually September in 2022. It was actually Father's Day. Fiona realised that Elizabeth had suddenly become quite active after dropping off. It was a bit of a flurry of activity, and then at that point, nothing else. And it didn't take Fiona long to cotton on to the fact that that was kind of Elizabeth's last little goodbye. So we were we knew what happened. Scans later that week kind of showed that there was no heartbeat with Elizabeth. We were, and it sounds odd, but fortunate with Elizabeth's positioning within the women placenta. She was up higher than Banksy, so the risks that she posed to Banksy were actually the lowest they could possibly be, but there were still significant risks. So we were told that we had 2 months to go, where Fiona had to carry both Elizabeth, who had passed away, and Banksy, with a focus on making sure that she did everything possible to secure Banksy and his health. I, as someone who wasn't physically in that situation, couldn't imagine what that's like psychologically. I saw from the outside what it did to Fiona, but I couldn't possibly imagine what she used to think at night time. She did used to wake me up and tell me all the stats about how well relationships or how long relationships last for after events such as this. So my mind was not only on Fiona's welfare, the rest of the family, but also just keeping a marriage in some way. So I felt like everything was kind of falling apart at the same time, with nothing I could do. We were fortunate that we made it through. We had scans twice a week with Banksy to just check on his welfare. We made it all the way through. And Banksy was born in December that year, healthy. Elizabeth was also born naturally. I couldn't commend highly enough our obstetrician, who reassured us the whole way, went out of his way to learn everything he could about what we were going through. And he supported Fiona more than just as a professional relationship, but as a really close friend, and probably had many conversations that she just wasn't willing to have with me. So it was fun, just fantastic to have that support while we went through it. The hospital experience was different. Giving birth natural birth in a normal birthing suite with midwives, but also giving birth to Elizabeth, who had passed away. It was kind of clear that the midwives and doctors were a little unsure of their approach to that situation. So we kind of did feel a little bit lost, and fortunate we have something such as Red Nose that we can reach out to, because they certainly did provide us with what we needed, the information we needed, even the practicalities around the paperwork that we had to complete. So Craig, I'll leave it there. If you've got any questions, happy to take them.
Thank you, Mark, for sharing that very personal story with us. We really appreciate your time and your honesty. And we will ask you some questions at the end, if that's okay.
Of course.
Great. So now I'd like to hand over to Professor Adrienne Gordon, who is going to give an overview of care after stillbirth and neonatal death, the new guidelines.
Okay, is that sharing okay, everybody? Okay, and you can hear me fine? Okay, so thank you so much, Mark, for that. Very brave of you to come here online and tell your story, and it's very important. And this is the reason why all of us are here, and the reason that we have guidelines that I'm going to talk about tonight. So I'm going to spend about 10 minutes. I'm going to switch a timer on so that I don't go for too long. So don't be alarmed if our radar goes off. I'm going to talk about these new guidelines, which are bi-national, Australia and New Zealand, and that were launched in April this year and are NHMRC endorsed. And I'll quickly go through their content and what's new and how you can access them. So just a little bit of history. This is the fourth version of these guidelines, which were initially released back in 2005. And they've actually come initially from a need to try and make sure that in reporting of perinatal deaths, stillbirths and neonatal deaths, that there was a consistent way to code and report those deaths. So these really were born out initially of a classification system, but then guidance around how to use that, and then recognition that care, support of families, investigations that are done, and the communication that happens is critical for families' experience and also to try and help with answers. So you can see here 2005, 2009, and 2018, and now 2024 are the versions of these. Really, this is born out of our Perinatal Society of Australia and New Zealand originally, and I'm going to talk a little bit about Improve and the education programme in the talk. And then when the Stillbirth Centre for Research Excellence has been funded over the last 8 to 10 years, then they have taken on the last 2 updates for this important guideline. And the reason we have these guidelines is it doesn't matter if somebody has miscarriage, if their baby dies before birth, during birth, or in the first few days of life, families always ask the same questions. They want to know why it happened, even if you have some idea already. They want to know what did they do wrong, or could they have done anything differently, which involves proper review of deaths to make sure see there was any risk factors. And they want to know, will it happen again? And unless we have a system and an approach to actually review, report, investigate, and support, we can't answer these questions for families. So these are the chapters in the guideline, and I'm really just going to highlight the parts that are new. So there is an introduction, an overall approach, and what perinatal loss care means. There is woven throughout much, much more in this guideline on cultural safety. There is a whole section on review and reporting and what organisations can do to support. But I'm really going to focus on 4, 5, and 6 today. So the perinatal palliative care is new, care in subsequent pregnancies is new, and the investigation section has had a significant update and has some resources to support. So
Adrienne, it seems that you have frozen. I apologise for our IT challenges tonight. Adrienne will just dial back in again and hopefully her internet connection will be more stable. Fran, whilst we, oh no,
I'm so sorry. I just fell out of that completely. I don't know what happened. I don't know where you got to, which slide you got to. Can you tell me?
You were just highlighting 4, 5, and 6 being the
Okay,
focus,
good.
I think.
Lovely. Thank you so much, Fran. Okay. I don't know why that happened. So, and sharing, I will try and just restart. Sharing is not turned on for me at the moment. Lacey, sorry. I'm so sorry. I'm assuming that one of my children is potentially gaming.
That should work now, Adrienne. Yeah.
Right. Yes, that's there now. Okay, great. Let's share this. Okay. Okay. So this first new section, section 4, is around perinatal palliative care. There are recommendations in each chapter that are evidence-based or consensus-based, based on the NHMRC guidance. And so this section talks about care planning from diagnosis through to birth, if that diagnosis was during pregnancy, and following through to management of the palliative care and the death. It recognises that this is a continuum and the importance of parent-centred decision-making and the engagement of community. And you can see some of the core principles in the chapter there. For each of the chapters and modules in the guideline, there are appendices, sample tools to use, like a sample palliative care plan, for example, that can be taken and used in a clinical setting. The next section, which is about care and subsequent pregnancies, has 15 recommendations. Many of them are grouped into these 4 areas. And some of these are evidence-based, mainly the ones that are more around treatments rather than approach to care. And that is because despite the importance of the holistic approach to care, in terms of the evidence grading for an NHMRC document, sometimes we have to put some of these things in as consensus recommendations. But this clearly talks to continuity, high-level evidence there for single point of contact and continuity in the next pregnancy, the importance of social and emotional support throughout, from first booking into whichever model of care has been chosen and all the way through, multidisciplinariness of the team, and individualizing birth planning with that parent-led decision-making. Throughout the guidelines, we have quotes from families. We've had a lot of consumer and community input into these guidelines, more than the previous versions. The next section is on investigations. I'm going to spend a little bit more time there because some of the resources we're going to talk about and that Red Nose can relate to investigations. So the guidance in this section of the guideline is to help healthcare professionals understand the appropriate investigations to be undertaken, how to talk and discuss with families about those investigations and to help improve the whole experience of that. And Fran's going to talk to some of that a little bit as well. So how do we actually do in investigations? I've just got these two papers here, which are quite far apart. So the first paper is actually during my PhD when I first started doing some of this work. And the second paper is after a close to $1 million NH&MRC grant funding in a national study. And you can see here that we haven't really changed very much over the time period. The first publication is 2009, and the second one's 2021. We do very well in terms of sending placentas and understanding if there's any issues with the placenta after perinatal death, but our autopsy rates remain low. And our unexplained rates, you can see the first study is quite low. That's probably one of the lowest documented, 13 to 15%, but still 29% in that more recent study. These are the latest autopsy rates from the AIHW, our national data, and you can see they really just show the same thing. So really less than 50% of babies that die have an autopsy performed. And we do more autopsies in the babies who are stillborn than in those who die in the first days of life. We also don't always do an assessment for contributory factors. So you can see here in only about a third of cases is a full assessment for what risk factors might be there, what might have contributed actually done. In terms of these investigations chapters, 33 new recommendations. We talk about core tests, selective tests, how to talk about tests, and cultural safety. And there are these flowcharts for neonatal deaths and stillbirths, and they are broken down into core things on the left, dependent on clinical presentation in the middle, some additional selective investigations. And it's broken down into mum, baby, and the placenta. There are listed alternatives to autopsy and what can be discussed if the family don't wish for an autopsy to be performed, what other options might be available. And we also know that despite these being the sort of best evidence available at the time, there are still some gaps here in terms of investigations that hopefully with the next version of the guideline we might know more about. So we'll know a little bit more about this clinical care standards. I'm going to talk about them in the next just minute or two. And we'll also know a little bit more data on whether a stepwise approach to tests prior to deciding about autopsy might be helpful. That's happening in a few sites in the UK, and real use of decision aids rather than information sources. So these things might come in the future. So this is the QR code to access the guideline. You can Google CASAND guideline, or you can click on the QR code. It's broken down into chapters. You can download all of the appendices and you can work your way around there. It is in line with the clinical care standard that was published in 2022. This is from the Australian Commission for Safety and Quality in Healthcare. And this is something that actually has information for parents, for health professionals, but also for health services to support best practice in bereavement care. It's also about prevention, but 9 and 10 in the clinical care standard tie in very much with the guideline. Last thing I want to mention here is there is a new program that's been tested in a trial led by Siobhan and Anne, you can see at the bottom. And this is an online program that parents can be referred to called Living with Loss. So it's been developed by a multidisciplinary team. It's got 6 modules with some practical strategies to support the grief journey in the short and longer term. You can access that yourself. You can refer people to this as a service, or you can register yourself as a health professional. I know many on the call tonight are health professionals, to have a look at the program and see whether you would refer your patients and families. The last slide is just to say we have an education program called Improve that has been running since 2009 around these clinical practice guidelines. It's face-to-face, and an e-learning program. It's across the country. The e-learning came in 2020 because of COVID that we all know about, and many people have come through that program, and the website is down there at the bottom if you haven't heard of Improve and you'd like to log on and hear more. Guidelines are endorsed by many organisations. A lot of people have been involved, and I'm going to hand over to Fran. Sorry, I went slightly over my 10 minutes because I dropped out there, and she's going to talk to you about resources for parents. Thank you.
Thanks so much, Adrienne. I'm going to cross my fingers here and hope that my screen shares correctly. Can everyone see that? Oh,
You got it, Fran.
fantastic. Okay, right. Okay, well, thanks so much, Adrienne, and thank you everyone for joining us tonight. I do have a little problem with progressing slides here. Okay, here we are. Sorry. It's great to have everyone here. And I would also like to acknowledge the traditional custodians of the lands from which I'm joining you, and that's the lands of the Jagera and the Turrbal peoples here in Brisbane, Meanjin. And I pay my respect to elders past, present and emerging, and any Aboriginal and Torres Strait Islander people who are joining this webinar. I also want to acknowledge all who've experienced perinatal loss and all who've cared for them, and the babies who are so greatly missed. And Mark, thank you so much for your beautifully moving story of your beautiful Elizabeth Fiona. The timing of this webinar coincides with World Patient Safety Day, which is marked each year on the 17th of September. And this is really appropriate timing because safety is a critical part of care after perinatal loss. Feeling safe, feeling supported, and receiving care that's based on the best possible evidence is vital to support parents as they face their loss and to help reduce the potential for longer-term psychosocial distress or trauma. And following on from Adrienne's great overview of the clinical practice guideline for care after stillbirth and neonatal death, I'm going to talk a little bit about Guiding Conversations, which is a parent resource that's designed to support parents as they face those many difficult decisions that follow the loss of a baby. It's a parent-centred version of the CASAN guideline that Adrienne's just described. We know that losing a baby at any time during pregnancy or soon after birth is devastating, and it involves suffering. And you can't take away the grief, the shock, the distress, but you can help. And we hear over and over again from parents how the actions of healthcare providers and healthcare settings can lessen or add to parents' suffering. And an important aim of the CASAN guideline is to put parents at the centre of decision-making and to encourage health professionals to work with bereaved families to give the support and information needed so that families can make the decisions that are right for them. All too often we hear that parents found out about options when it was too late. Missed opportunities and regret can add greatly to parents' grief. Parents need and want clear and timely information about all their options to support them in making the decisions that are best for them and best for their baby. There are so many confronting and time-critical decisions at a time of intense shock and grief. And these decisions begin right at the beginning with the first signs of concern that something may be wrong. And then there are decisions about birthing, spending time with baby, investigations, and that's just to name a few. Parents need to know what's possible. So in developing our parent version of the guideline, our aim was to give parents access to the same evidence-based information that's available to healthcare professionals, to support parents in exploring options for their own care and for the care of their baby, to support shared decision-making, and essentially to give parents some agency at a time when they often feel that they have very little control. And many people have been involved, as they have been with the CASAM guideline, including many bereaved parents who've helped to shape the resource we've developed. And Guiding Conversations reflects a partnership between the Stillbirth CRE, Stillbirth Foundation Australia, and the Perinatal Society of Australia and New Zealand, and of course, Red Nose have had a lot of involvement. And the resource is currently being used in many Australian maternity settings as part of the Red Nose and Stillbirth CRE suite of resources to support best practice care. So what we wanted to do was to convey the content and the philosophy of the clinical practice guideline recommendations in a way that was appropriate and useful for parents and that was sensitive to their needs. And we turned to the Guideline International Network, who have established processes and clear steps for developing effective patient versions of clinical practice guidelines. And of course, we also turned to parents and healthcare providers. And in doing that, we went from our clinical practice guideline to Guiding Conversations, corresponding parent version that's intended to work hand in hand and sit alongside the clinical practice guideline to support that communication between parents and their care providers. And it's intended to complement and enhance face-to-face conversations with healthcare providers. It's definitely not intended to replace those conversations. It's also not meant to be information heavy or to replace a lot of good information that already exists. What the aim is to help parents identify what it is they might need and how and where they can find it. So in the development of Guiding Conversations, we applied features drawing on the Guideline International Network that reflect best practice in developing consumer-centred health materials. And we also incorporated what bereaved parents told us in our consultations about what was important to them. So just a very quick walk through a few of the key features that we have incorporated. So one of the big considerations is about avoiding overwhelm. And quotes from parents were viewed as vitally important, so ensuring that parent voices were included throughout, but also recognising that parents might read only certain sections. So in recognising that, what we did was try to ensure that quotes and text boxes were carefully selected so that they do provide a standalone narrative that captures the key important messages if parents feel able to read small bites only. This was something that parents told us was really important. Some parents want to read everything they possibly can, but many parents find that at this time, too much information is just totally overwhelming. They can only take small bits at a time. Putting words around difficult questions that can be very hard to articulate and hard to ask, or even questions that haven't even been thought of, is a key feature and one that parents really welcomed. And something we heard repeatedly from parents was that they had questions, but they often feared that some of their questions were silly, their word, so they don't ask. And what happens is that they carry those unanswered questions with them way into the future. Finally, we actively invite parents throughout the guide to think about what's important to them. We know there's no one right or wrong or the same answer for every parent. Grief is unique, but we wanted to invite parents to be able to express their concerns to help identify what the information they needed at this time was, and to support them in their conversation with healthcare providers. In summary, what we're doing is trying to provide parents with evidence-based information, so that's from the CASAN guideline, using an evidence-based approach, using the Guideline International Network approach. And currently, Guiding Conversations is being used in a number of maternity hospitals in Australia. For those who are joining this webinar, I'd really love to know if you are currently using it, if you're aware of it, what you think. Please feel free to pop anything at all in the chat. We'd love to hear from you. We have received a lot of positive feedback, both from parents and from healthcare professionals. And our goal is for all bereaved families to have access to this guide when they need it. And we do acknowledge recent funding from the Department of Health and Aged Care that's helped to make this resource available throughout Australia. In conclusion, I just want to remind everyone how important best practice in perinatal bereavement care is. And as we hear repeatedly from parents, respectful, supportive and compassionate care is everything when a baby dies. And we all must continue our efforts to ensure all bereaved parents receive the best possible care. Thank you.
Thank you, Fran, for your very clear presentation and your excellent slides. We'll pass over to Skye now. And as I said, we'll come to questions for everyone at the end. So Skye, if you could please start your slides, we'd appreciate it.
Thank you, Craig. Lacey is very kindly going to share the slides for me. I'm currently in a caravan park with my family going to a conference. And so the internet is a little bit slow. And so we figured this will be the best way forward. Thank you for doing this, Lacey. All right. Yeah, perfect. We've got it. All right, so I'd just like to start by acknowledging the land that we're on. I'm currently on Yuin country in the south coast of New South Wales, and I pay my respects to elders past, present and emerging, and would also just like to pay respects to our little star babies, those little babies who came but couldn't stay. So talking about Star Baby, and what a journey it's been. You know, the story of Jiba Pepeny has been a big one. As the nation's first support guide for Aboriginal families following stillbirth. And it was in 2019 when the calling for this work really started. I read the 2019 Mothers, Babies and Children's report and gasped out loud when I read that the gap was widening regarding deaths of our Aboriginal babies in the perinatal period. And not only this, the rate of stillbirth within our communities was seen to be increasing. In the rural, remote and very remote areas, it was even rougher. The gap extends even further. You know, Mob in NT have the highest rates of stillbirth in the country. I couldn't believe what I was reading at the time, so I kind of went down a bit of a Google rabbit hole to see if there was anything out there for business, bereavement for Mob after stillbirth, and I couldn't find anything. And obviously it was something that I couldn't let go. And 4 years later, Star Baby, Jiba Pepeny, was born and launched into the world. So the guide itself is culturally safe and responsive guide for Aboriginal families following stillbirth. It supports the family's journey from when they first hear the news about Bub passing away until 3 to 4 months post-birth. The guide in itself addresses key clinical elements of the journey, including birth options, investigations and tests for Bub, but it's all imbued with a cultural lens. And our Aboriginal ways of knowing, being and doing is in the heart of it. We know that that's our protective factor and not our risk factor. And the guide carries and supports that. The guide itself, it was made by Aboriginal people for Aboriginal people. So Lacey, I don't know if you can click on to the next slide. So I can't share the story of Star Baby without acknowledging my family. So this is my family, and I always like to say to people, so how was Star Baby born? And Star Baby was born because I was born to do it. I'm Skye. I'm Wergaia and Wamba Wamba woman. I'm from, which is Murray River, and we're the Skye people. So our connections stay with the stars and the skies, and we have a lot of Dreamtime stories to that time. And so I always have to share the story that, I couldn't do this work without these are the people who raised me. There's my mum, and I pretended to be fancy on the left there. We're having a little tea party in the garden. My beautiful Nan having a little bush picnic out at home, and my Uncle Mark about to take us on a fast motorbike ride, no doubt. So I'm a midwife and have been for 18 years. And as an Aboriginal midwife, it's my cultural role and responsibility to do what I need to ensure that Aboriginal mamas and their babies are safe, alive, well, and together. You can go to the next slide. Thanks, Lacey. So coming back to Star Baby, as I mentioned earlier, knowing the facts and stats, I applied for a fellowship through the Stillbirth Centre of Research Excellence and was lucky enough to be the successful recipient. It was my first time entering the research world, which felt like another language to learn. But what I had to do was stay true to who I was, first and foremost, as an Aboriginal person. I know that, research can seem like a bit of a dirty word. And so we had to approach this with care and consideration, considering as well on top of the fact that sometimes talking about death from mob can be taboo. So it's sensitive and it adds that extra complexity. It had to be the right person, the right people in the right places. I had to sit with families and really just have a yarn. I think what I like to think of Star Baby is it became a call and response project. So a deep listening project. In my language, we have the word that you can see up here, Nyanila, and it means to listen continuously. So it's listening with your eyes, ears, heart, listening with words beyond just talking. The families called and I responded. And the project really started forming and coming together, connecting the dots to become what it is today. It's filled with support and care, information, options in care, what you need to know when you're in hospital, but fueled with a cultural lens. It's our Aboriginal way. We know, one mama said to me, she didn't know that her baby would be so cold to touch. So I carried her words with me and I placed them gently in the guide so other families in the future knew. I wrote, after a while, bub will be cool to touch, but you can still hold them close to your warm heart. Another mama said she didn't know how to have the hard yarns about tests, but like autopsies afterwards. So she just shut down in communication and did what she thought she was supposed to do, but she didn't want to get into trouble. Jiba Pepeny took those words and holds them in the support guide, and it says something like, even if it feels tough, you can still have these hard yarns about Bob. You're strong enough to do it, even when you don't feel like it. Many families mentioned their cultural needs were not considered or acknowledged at the time. Many felt too shy or too ashamed to ask for what they needed and wanted. So Jiba Pepeny is filled with cultural ways that you can honour Bub whilst in the hospital. Paint Bub up if you want. If you're a river mob, get someone to go out and bottle some of that river water and bring it in so you can wash Bub's hands and feet in it, connecting them to country and culture. Same if you're sea country mob. If you're desert or bush mob, if you can get some of that red sand or ochre and mix it with water and gently rub it on Bub. You can bring country to hospital. For many Aboriginal people, when someone within our community passes away, the community have a period of time called sorry business, where particular roles, responsibilities, ceremonies, song and law must be adhered to. Aboriginal people's needs in times of sorry business is complex and needs to be respected and integrated within our care. And this is lacking for all kinds of reasons, but it's something I definitely believe as healthcare professionals we can and will get better at doing it. And I think whilst Jiba Pepeny is a tool for families, it's also a tool for insight and for education for staff as well. I believe it does have the potential to create positive change within our services when we're caring for Aboriginal and Torres Strait Islander families following stillbirth. And we know that cultural safety and responsiveness can lead to safe care, which is more likely to be free from racism, respectful of culture, and will give power back to our families. And if used the right way, it has the potential to promote healing, foster safety, and nurture the future of the mother and father. If they have more baseline. The last quote that I want to share, thank you, shows us that I've done the right thing. When I look at this guide, I'd feel strong in a sad time, I lost my baba long ago and there was nothing. Looking at this sees me as who I am, an Aboriginal person, and my needs might be different to Gobbers. I'd feel stronger at speaking up about what we want for Baba because of this book. Yeah, this book makes me feel stronger. So thank you. Thank you, Lacey, for being screen sharer.
Thank you, Skye, for your presentation and the amazing amount of work you've done on this project. I'm sure it will be invaluable to members of the Aboriginal and Torres Strait Islander community around Australia, but also to staff providing care for those families. So if people would like to post any questions in the chat, we'd be very happy to answer those. But whilst they are starting to come in, I thought I might start by asking Mark some questions, if that's okay. Mark, you've heard a little bit about the Guiding Conversations book that was written. Do you think that book would have been helpful for you?
Yeah, certainly. I think, and it was touched on a number of times. For me specifically, trying to get as much information as possible was paramount to kind of understanding what was going on and what our options were. We were faced with a number of decisions to make, so making sure that we felt that we were well informed was paramount. So yeah, I mean, I looked at the document that was shown tonight, and it certainly did cover a number of areas where we talked a lot. Yeah.
So you spoke a lot about your response to the loss of your baby and how you did many practical things to try and move forwards and build something for the future. What advice could you give the many healthcare professionals that are involved listening to tonight's presentation about helping fathers through the process of perinatal loss?
Fathers need to feel helpful. I mean, I think a lot of the conversations that I had with doctors, a lot of it was focused on Fiona and what we could do with Fiona, but there was very little of what I could do to help. So feeling helpless as a father and a husband is probably the worst place to be. You do want to be able to fix things. You do want to, as you said, you want to paint the picture of the future that's going to be better. So really working out of how you can bring fathers into the conversation about what they can do to help. We're desperate to. We just struggle to find where we should.
Okay. And you mentioned that you engaged with Red Nose after the loss of your baby. What particular resources that Red Nose offered did you find the most valuable?
I think the hospital to home for us was invaluable because, as I said before, and no fault of anyone, the unique situation of giving birth to Banksy and also giving birth to Elizabeth after she had passed, we felt a little bit lost. We weren't really in one spot or the other. So how we were treated, some midwives, somewhat ignored Elizabeth and just focused on Banksy's, and others really kind of focused on Elizabeth, and which for us felt like they were taking something away from, the fact that we just actually had our fourth child and he was happy and helpful. And that's just the unique situation of these people trying to balance the conversation. So that having Red Nose there kind of gave us that voice that wasn't in the room with us at hospital, and really helped with the practical matters of, we knew we had to do paperwork for both the birth and the death. We had no idea how to approach that, and the hospital really didn't know what we should be doing. We wanted to keep it as obviously as simple as possible, so that it added confusion in the hospital wasn't great, but Red Nose really did help. And it's obviously Fiona had someone to talk to a significant amount of time about what she was feeling. So yeah, without Red Nose, we would have been quite lost.
So there's a message that I've just seen, which I'm not sure if everyone can see, but SMS for Dads is a service that Red Nose works with, which provides text messages to dads going through this process. And certainly we would encourage people to engage with that service so Red Nose can help both mothers and fathers and broader families involved with the process of loss. So does anyone else on the panel have any questions for Mark before we move on? If not, I would like to ask Adrienne some questions. So I've heard many people say that my hospital has a local guideline for the management of perinatal loss. Should I follow their guideline, or should I follow the new one that's been published and supported by NH and MRC? How should I manage this in my clinical environment?
Yeah. So I think in terms of the best available evidence and the principles, I think the national guideline has all of that. But sometimes there is still a place for a local guideline that's about step-by-step things that happen in that centre. So I think there is probably a place for both. But I think if there is a local guideline that's recommending different investigations, or doesn't have an approach on cultural safety, or doesn't have anything about communication, then I would just be going for the national guideline. But certainly local logistics are quite different, and even access to services such as hospital in the home is different depending on where you are in the country. So those sorts of local things are really useful to have in a practical version that you centre.
So I noticed from your slides that the autopsy rate is still very low in Australia. Now, I'm very aware that that is very site specific. I'm lucky to work in a site where we have a very high autopsy rate, but that therefore must mean there are sites with very low autopsy rates. Why do you think the rate has remained so low, given that we know the information from autopsy will change clinical management in about 1/3 of future pregnancies?
Yeah, look, I think it's a combination, Craig. So I think it's been slowly decreasing. So it's not just remained low, it's been slowly decreasing over the last 20 years. Same in other countries similar to Australia, UK, Canada, US. And I think it's a combination of things. I think some of it is lack of training of healthcare professionals in actually what an autopsy is, as well as how to communicate to families about it. I think some of that is related to, the fear of what happens from both families and healthcare professionals. that understanding plays out into not wanting the baby to go somewhere where you might feel the baby's not being looked after, not wanting the baby to go through any more when they've gone through enough already. I think there are assumptions that people often make that often aren't always true, but people make assumptions on families' cultural or ethnic or religious background. So I think there are multiple reasons. But I think what we do know from the evidence is that the best chance we have of getting enough answers for the family, in even important negatives, is an autopsy and placental examination. So despite all of the other tests that we have, those two things are still the best tests we have available. But as I say, there are centres, so Great Ormond Street in the UK is trialling approach where they do very rapid assessment and review of the placenta, and an external exam of the baby, get that back quickly, and then make a decision about in which cases is the autopsy going to potentially be the most useful. So that sort of setting obviously only works if you have a pathologist on 24/7 who's going to look at that placenta and get the data back to you and the report back to you in time for you to make that decision. So I think that evidence might be coming, but at the moment, these are our best tests. And even, an external examination by a pathologist or a limited autopsy can be extremely useful. So there are all those options in the guideline as well.
Just while we're talking about autopsy, Skye, I was wondering if you could provide us some guidance about how is most appropriate to discuss autopsy with Aboriginal and Torres Strait Islander families.
Thanks, Craig. I think, again, it's going to be something that's very individual. Culture-wise, traditionally, that's not something that we would have thought about doing, but again, it really varies. And so in terms of the conversation, I guess the best way to go about it is, as you would with anyone, is just, quietly, calmly, kindly. And, for a lot of Aboriginal people, there can be some triggers or past trauma about accessing a hospital system in the first place. And so it's just recognising that there may be some past trauma history that might prevent an Aboriginal person from being able to maybe know what questions to ask, or not necessarily know what questions to ask, but feel safe in asking them. So I guess it's around having the conversation in a kind and gentle way, letting them know that they can come back. You don't have to give an answer right now. You can come back to the conversation when you're ready, and taking, just that gentle, slow approach, and just checking in maybe more than you would someone else, again, because it could be around that not knowing the information, or not feeling safe enough to be able to say yes or no to a procedure that they might be talking about.
And what, in the loss process, when do you think is the most appropriate time to bring this up? For example, would it be before, if you know a baby is stillborn before birth, do you think it would be better to speak about this before birth or after birth, or again, it's just something to individualize to the family?
I think, again, it will be something to individualise, but saying that for a lot of Aboriginal families, because we have sorry business for a lot of us, our law and our protocols that we adhere to as different members in the family and community. So sometimes for conversations like that, it's better to have the conversation earlier, because for a lot of families, it might not just be the mum and dad that have the final say on what happens to baby. They might need to consult with an elder. They might need to consult with someone else within their family to have that final decision. So I'd say in that regard, the earlier the better.
And in terms of the parents or grandparents or elders, culturally, are they supportive of this concept, or is this something that is very challenging for them?
again, it depends. I feel for that it's very dependent on where you are. I feel like, you know, speaking for myself and for a lot of families, Koori families within Victoria, that there seems to be more acceptance in it. But again, you know, it really varies, and it depends where. And I think some of it is just really around just the education being given in a gentle, safe way, so that people are learning exactly what's happening. Because again, there's that past trauma in hospitals of, you know, babies being removed and babies being taken, that, you know, some of that translation might not come across as to what's happening with your baby. So again, it's just really about having those conversations as many times as you need, so the family's understanding what is actually going to happen in, say, an autopsy, what's going to happen afterwards. So it's just, yeah, like a lot of conversation, a lot of openness and transparency.
Okay, great. Adrienne, you're often in a position where you get to talk about autopsies with families. Are there particular comments or questions that you find will often sway a family one direction or another if they're uncertain about going down that pathway?
Look, I think that's a bit tricky. I think every family is different, but I think the first person that brings up the topic is often the most important. So if the first person, particularly if that person is, I don't know, the obstetrician or the midwife that's looked after them for the longest time, the person they've got the trust and relationship with, if that sort of person suggests early on that having an autopsy might not be useful, that is very difficult to be able to have a balanced transparent discussion with the family with autopsy as a potential investigation, because I guess most families, the natural instinct is actually to not want their baby to undergo that examination. And if somebody has already given you an option that you probably don't have to do that, it's very difficult. So I think I would definitely say I've had lots of experience of that. That's very difficult. I think, parents are more likely to consider or ask for an autopsy when they really it was very unexpected, and there was no clue around what was going to happen. So particularly the stillborn baby at term in a previously normal pregnancy, for example. But I think other than those two, I think it is very dependent on the family and their previous experience and background, etc.
The two things that I've found have been most valuable in counselling would be to reinforce to the families the benefits for future pregnancies. I think many people don't realise how important that can be. And I think the second thing that I think many families find valuable is to know that they can very comfortably see their baby afterwards.
Yes, I agree.
Because it's done with very careful incisions, that it's like an advanced surgical procedure, and they or members of their family would not know it had been done after the process. And
I think that's very true. I think knowing that you can see the baby afterwards, I think many families don't know that. And so I think when you say that, I think people often think, well, it must be okay if I'm able to go and meet my baby again afterwards. So yeah, absolutely agree with that one, Craig.
So one of your slides caused me great concern, and that was the one saying that only about a third of families had someone looked at the risk factors for stillbirth after their loss.
No, that's the contributory factors as part of the perinatal audit review. So, our classification system, and I didn't go through this chapter in detail, but our classification system at the moment, we have multidisciplinary review of deaths, as you know, and a classification code is given, but also there is the ability to go through in 3 different areas, contributory factors that might have contributed to the death, and whether they were significant and the death was possibly related versus definitely related to those contributory factors. So it's that formal contributory factors review that is not always done. And in some settings, those things are only done if the death has an adverse event review or an RCA, depending on which jurisdiction you're in, versus this being a routine part of review and reporting of all perinatal deaths, which is what the guideline says.
So why do you think that rate is so low?
I'm not sure. I think in some places it might be resources, and they may find it hard to get together that multidisciplinary team to review all those deaths in that detail. It does take a fair bit of organisation. If you're in a smaller centre, it might be significant in terms of workload. In some settings, people are doing this in paper, and so although it might be being done, it's not being reported at state or national level. So it might be a sort of underreporting on that national data. And I think really until the last few years, even though the guidelines included this contributory factor review, it actually wasn't directly linked to the classification. So it wasn't actually built into any electronic systems as part of the classification, which it now is certainly in New South Wales and Victoria. Queensland have a sort of quality review process. So I think depending on where you are in the country, the ability to be able to do this easily and record it easily has been slightly different as well. So I think that has improved too.
So the improved program that you presented today is excellent, and I would highly recommend it to everyone. How do people sign up to do that workshop?
Okay, so at the moment, we're still managing the central sign up through the CRE. So you can go into that Learn at CRE. You can click on the Improve and register for a workshop. Depending on where you are and what is happening in that jurisdiction, that might be organised differently. So, for example, in New South Wales now, that's a combined organisation between the Clinical Excellence Commission and the CRE. So it sort of depends a little bit where you are. If you're in the Northern Territory, they have now all been trained up and they're running that with the support of the NT government. So there is still a central input, and then you will be directed to wherever you are in terms of organising that workshop.
So Fran, your the work that you've done with the booklet for families, when do you think is the most appropriate time to give this to families who've experienced loss?
Thanks, Craig. That's an important question. And I think in response to that, I would say as soon as possible. We know that parents do face difficult and often confronting decisions very soon after a diagnosis is made of a baby's death or impending death. So having access to supportive resources such as is so important right from the beginning. That said, an important proviso is that it occurs in the context of a conversation. The Guiding Conversations title refers to guiding conversations for parents, but also for healthcare providers. So it's important that we don't just give parents information without that supported conversation around it. And I'd also just like to add when not to give parents the resource, and that is in a pack when they're leaving hospital, because we've recently completed a survey with Red Nose, the online bereavement care survey, and one of the things that came up resoundingly was if you give parents a bunch of resources in a pack to take home, they will often never look at them. It's overwhelming, and it's a missed opportunity to have supported parents in finding the support they need.
Okay. And what comments have you had from families who've used this guideline so far?
Oh, really pleased to say, Craig, we've received quite a lot of unsolicited feedback from families and also from healthcare providers. And yeah, I think at different points in the bereavement journey, the resource has helped parents in making decisions and different types of losses as well. I think just being able to take from the resource what you might need at a particular time. And that's something we've tried to do. And it's some of the feedback that we've had from parents is that they were able to just sort of pull out the bits that they needed. And yeah, I think that's important.
Thank you. So something that has been being used more frequently over recent years is post-birth MRI for babies that have been stillborn. I know that some centres are doing this more than others, particularly some sites in Melbourne and in Adelaide. I was wondering, Adrienne, if you'd like to expand a little bit on the role of MRI post-birth.
Yeah, so we did spend quite a bit of time, the evidence review and the evidence review committee, who were working very hard under the leadership of Philippa Middleton, Annika Bowman in Adelaide, and each of these chapters has a big technical report and review. Now, at the moment, I guess there are two reasons that it's not in there as core investigation. And the most important is that it's really around availability and the fact that this guideline needs to be able to support families no matter where they are in Australia, regional, rural, whether they have an MRI available or not. There are centres showing that it can be useful, but they are centres that have got access to it in a timely manner. And the centres that seem to be doing a very good job, and I see what Catherine's written in the Q&A, but the Adelaide group work very closely with radiology and the pathologists, and they actually put that MRI finding back into the pathology report, and they all discuss the pathology report together, and then the family get that report with all of the information, which is really, I think, very impressive. But they also run that MRI on a Saturday when there are no other people in the scanner, and they would do all of their deaths from that week on that Saturday morning. So I think they all come in and do that potentially out of hours. So I think there are some logistic issues around being able to put it in as recommended. And I think the other thing that the evidence would say is that the MRI is potentially most useful in some of the concerns around genetic conditions, potentially in the situation when the family decline autopsy, but also the usefulness of the brain MRI also depends quite a lot on the timing of the death of the baby. So it might be more useful in a stillbirth near term where there hasn't been many days between the death and the birth, or a neonatal death in the first days of life. So I think we still don't have high enough level evidence to say it's most useful for these babies in this situation. Therefore, it can go into high level recommendation. But I do think that people are doing it. I agree, and people with resources are doing it, and we'll get more information about that over the next few years, I would think.
Great, thank you. There's quite a long question, which I think might be easier if I just read it. So this is a question from a social worker working at the Royal Women's in Melbourne, and she's been doing some research into the experience of care after pregnancy loss. And one of the things that she's found in her research is the impact of language and communication, both in hospital and in the community, particularly when people are asked things like, is this your first baby? When different people are trying to build rapport. And I guess the question is how do we think we could shift some of the common language that's used to support bereaved parents and families?
I might start there, but I might then hand over to Fran, I think. But the only thing I was going to say there is that there's a very good set of sort of resources on the back of a campaign that SANS did in the UK called Finding the Words for different situations to try and support communities, families, friends, healthcare professionals about the sort of things that families say are most useful versus least useful. That's kind of a kind of practical suggestion. But I might hand over to Fran, who's probably got something more erudite to say here.
Thanks, Adrienne. That was a really good response. But yeah, totally agree. And I think it's such a difficult question for parents. We hear parents so often say that it's such a hard question when you're asked how many children do you have. And I think in terms of hospital care, healthcare professional care in subsequent pregnancies, I think in our guideline, there's a specific recommendation around talking with parents about their previous loss and how they would like to incorporate discussions around that in their subsequent pregnancy. So that's kind of really, in that context, putting it clearly on the agenda and making sure parents have the opportunity to talk about their previous loss in the way that they wish to. As far as community responses go, well, this is it's a long process, and it comes back to building public awareness and understanding. Again, in the survey that we've done recently with Red Nose, we saw that family and friends are the first port of call when it comes to support. But yeah, just equipping family and friends and the community more broadly to understand the issues that are important and how, as you said, Adrienne, how we can respond appropriately in ways that are sensitive and helpful for families. So really about that continuing challenge of building awareness. But it's a really great question and an important one.
So, Mark, you got to start tonight. I'll give you the opportunity to end tonight. What were the most useful things that people provided to you or said to you after your loss?
I think for me, it was really understanding that there is a group around this, that we're not the only ones to have gone through this. So not to the extent of normalizing what we were going through, but just understanding that, look, we were part of something, and Red Nose did that exceptionally well. And also, they really gave that friendly voice to sometimes what could have been quite a clinical conversation about what was happening. So for us, it wasn't certain words that were said, but it was just that feeling of connection and support that we had that made it much more bearable.
Right. Okay, I'd just like to pass on a message for Skye. She is sorry she couldn't get back into the conversation due to some internet issues where she is currently. I'm just going to share two last slides before we finish. I'd like to thank everyone for their amazing contributions tonight and to all of the work that they have done in preparing for this. This slide here shows you the QR code where you can get the parent version of the guideline, and this code will direct you to the Guiding Conversations booklet and also the Star Baby booklet for Aboriginal families. And I'm pretty sure from that code you can then print out the document yourself. Is that correct? Yep, I'm seeing some nods. Yeah, that's probably the most efficient way of getting it at your site. Secondly, this here highlights the services that Red Nose offer families with loss. It's a 24/7 support line where families, extended families, or others caring for families with loss can call to get additional support. And then the last reminder for tonight is the hospital to home outreach support program. So this support program is available within 3 months of loss to a bereaved family who have experienced the death of a baby or infant through stillbirth, neonatal death, or some unexpected death of an infant. And as Mark said, this resource has been very valuable for many families, and I believe it'll be very valuable for many families in the future. So thank you everyone for logging in tonight. If anyone has questions that they would like to ask any members of the panel, please don't hesitate to send them to us and we'll aim to address them for you. This will be available online if anyone wants any further information, particularly the QR codes. Thank you again to the speakers, and we look forward to seeing you all again for our next research and education series. Thank you.